broken brain.
Recording in progress.
Welcome back, everybody. It's the Broken Brain coming to talk to you about your dose of psychological health today, this week, this however often it's been since the last episode. We'll see. You'll have to measure that yourself because that's the future. I'm living here in the past when we're recording. It's your host, Dwight, here to share with you a pretty exciting a topic. I've been doing a little bit of interviewing and talking to people who are involved in different programs that help people, particularly people who might find themselves at odds with the criminal justice system or some other societal obstacles and barriers due to addiction, mental health, and other things like that. So as we're highlighting some of those things, which is very, very near and dear to my heart, I was very grateful to have Briana Daniels, who's the nursing supervisor at Pioneer Human Services. And you work with the Crisis Center in particular, here to tell us about some of the programs and things that you're doing in the state of Washington. First of all, did I get all of that correct?
Yes, you did. It sounded great.
Oh, good.
She's going to be thrilled.
Yeah, I didn't want you to be, who knows? Sometimes I might do something like that and find out, no, I'm in Tennessee and we do something completely different. Oh, okay. No, that's that pyromania clinic in, idea that I just made up. Welcome to the Broken Brain. Really glad to have you. So tell people a little bit about yourself and, who you are and what you do over there at Pioneer Human Services.
So I grew up on the East Coast. I'm originally from New Jersey. I went to school in Philadelphia. My whole career, I've kind of been drawn more towards the different social determinants when it comes to being a nurse. So I worked at level 1 trauma in West Philadelphia. I did hospice for a little while. I did jail nursing in Vegas. And then when I came to Washington, Spokane, I started dabbling more with the mental health. So I worked with teenage girls who are in recovery with mental health. And then I have ultimately landed at Pioneer. And so it's a 46-bed inpatient crisis medical detox facility. And with that, so 46 beds broken up, you have your mental health side. And that is, basically for everybody who is either suicidal, homicidal, or in a state of psychosis. Then you have the medical detox side, and we help facilitate, safe withdrawals, right? And then we have a co-occurring side, and that is for both of those things because they do live very often simultaneously within the person. And that's a 28-day program, and we try and set them up with long-term housing. We try and get them their different needs met, whether it's court dates or, get them set up for just resources in the community, our primary care provider. Sometimes it's something as simple as needing glasses, different things like that. And so when we have them for that 28 days, we are better able to set them up for success in the community.
There's a real case management factor to it then, basically, which I always look at that as something people don't think about when it comes to mental health care, is that, with your therapist, you're not going to be filling out a application for disability or getting a pair of glasses or finding out what your medical benefits are. Now, a therapist may talk to you about that process or encourage you throughout that process, but they're not going to, whereas a case manager might actually say, okay, let's fill this out. Come on in at this time and sit down. If you need any help, I'll kind of help you, or I'll go to your house even, depending on the program,
Yeah,
not
absolutely.
determining what you guys do. But anyway, a very, very important part of that. And also not present in every area or even every state to the same degree, let's say. It's something that when it is available is such a game changer for people.
Yeah. So, we were talking about success, right? I go back to Maslow's hierarchy of needs. So if we want somebody to be successful, whether it's in sobriety or mental health, we need to ensure we have basic needs met. And that includes food, housing, and then we can climb that pyramid. Then we can reach that emotional safety state. Then we can reach happiness and a fulfilling life. But without those bottom building blocks, we're not going to get anywhere. And so the team that I work with, that I adore, there's a bunch of us. We have the medical side, we have the mental health side, we have the SUD side, we have the peer side. And so we all come together and collaborate and figure out what can we do to serve this individual best. And I'm not going to put some, sprinkle some, fairy dust on it, because that's not the reality. It doesn't always work out to be a beautiful story, but we have had some beautiful success stories, and those are the ones that we hold on to.
Excellent. Yeah. It's very interesting when you look at that, to say, if you can do a lot can happen. If you do a little, though, a little can happen. And that's a weird thing that we tend to think in absolutes oftentimes when it comes to this kind of stuff. In fact, I find a lot of times in mental health care, defining what does it mean to be healthy is just like in any kind of addiction treatment, defining what does it mean to be sober, and what does it mean to be safer and healthier. And people don't think about that. We tend to think in all or nothing terms.
Yep.
Quite a lot.
Well, often, things. Yes, we do. Yeah. You either have to do this or, something, I don't know, but you're absolutely right.
Now, how, to mention a little bit, you mentioned, I think most of those were pretty self-explanatory. SUD, did you say? Is that a certain population, or tell everybody what that means?
So an SUD counselor is somebody who specializes in treatment addiction, right? So they sit down and they figure out frequency of use, what your support system looks like. And so it's this whole evaluation process, counseling. They do groups, they do a variety of different things, basically to determine quote unquote level of care. Right. So if somebody is if like inpatient seems appropriate because this person's been using, meth for the last 2 years versus they had, they relapsed, they used it once last week. They're in a, kind of a panic mode. They might qualify for or be better off in something like an intensive outpatient versus an inpatient setting. But a lot of the programs in Washington, in order to put some of your past behind you, you need to have one of those evaluations. And so they sit down, they fill out the evaluation, and they're a counselor. So they do all of that. And it just helps us one more step towards, kind of living a little bit. I don't want to use the term freer, but I think that kind of is appropriate in that setting.
Mm-hmm. Do you have programs that tie in with your program that have to do with actual, like the practical side of legal charges and things? Do you? I know I talked to the program Thresholds a little while ago. It's in I don't have it in front of me what state they're in, but anyway, they were able to work with people even before, or it was a way to avoid getting charges. Their state allowed them to do that. I've worked in connection with the drug court program, which will either reduce or drop charges. You have to actually get charged and plead guilty, though, to get into a program like that. So there's different approaches. Sometimes there's that carrot or stick to get people in, and just how does it work with the programs you are familiar with?
So we are a jail diversion program.
Okay.
And because of that, what happens, we are a low barrier program as much as possible. From the medical side, I do have to be cautious in terms of safety. But we will have law enforcement come in. They pick somebody up, whether it was in the Walmart parking lot or downtown. Sometimes they don't have pants on, but they come in and we do what we do. And it's purely volunteer. That's the beautiful thing about my facility. They don't have to be there. And so that makes my facility a safer facility, and it's more conducive to healing and growing and learning because you have people there who want that opportunity. So law enforcement will come in, we start the process, we do a mental health evaluation, we do a medical evaluation right before you even come back on the milieu. All of those things get completed. We're doing that UA, the breathalyzer, all of that stuff. And so a lot of times those guys don't have any charges. They're just being brought in. Instead of going to jail, they're coming to us. And so law enforcement brings them in, drops them off, and that's that. So
it's a cool thing to be able to avoid even being issued charges, because that can be such a huge thing for people to later on clean up, even with them reduced. I mean, you still have to go through a process oftentimes to actually remove that from where it might show up on a record, right? That type of thing. So yeah, that's a great thing. I like that a lot. The other thing I like about it, that it's kind of interesting, and I'd love to hear what you think about this, but there's this side kind of conflict inherent to court-ordered, or maybe you could put it forced treatment. There's this weird dynamic. I mean, as a therapist, and I've had a myriad of different experiences, but it was interesting for me working in a program where 99% of people who walked in the door were court-ordered. It was community mental health. Most people, if they were going to go get their own treatment, would probably go to a private practitioner or someone on their insurance. But we had occasionally someone would come in. And I knew multiple therapists who had worked into this program for their whole career, and these types of programs. And a couple of them would say, here we go. Here's one of these self-referral people. They're not going to get better. And for me, who I'd worked in some different private agencies as well as just clinics and things, I was like, well, I just kind of did therapy with them. And I thought, wow, if someone's coming in on their own, that's an advantage. That had been my experience having met people. And if you trusted them, they seemed to do well. But if the norm in the culture is, well, if you're not forced, you're not going to get better, buddy, then I'm probably not going to get better as likely. The program then has failed me.
Well, so it's really fascinating you speak to that, because when somebody comes into a facility, right? And of course, when you're talking about law enforcement bringing you in, still kind of debatable on whether or not it's, voluntary, but we're talking about the level of change, right? Or the stages of change. And so, when we get to that point where they are detoxed, they're feeling a little bit better. Do you want to stay? Do you want to go to another facility for, 90 days, 60 days, whatever it is? They're able to think clearly and make decisions of their future. And sometimes we just do the medical detox and they leave. And that's okay too, because we're safely detoxing them. Of course, we discharge them with, Narcan, all that kind of stuff. But it speaks to those, how do they want it and where are they at?
Yeah, that's a huge part that unfortunately when people are in treatment of all kinds, doesn't matter. One of the things that can be tricky is trying to be fit into a program rather than having the program discern and figure out what you need. And I know why programs do that, because if you have a big bunch of people, it's easier to have, and to some extent, I guess you have to have, here's the blanket rules, policies, etc. But then on the other hand, man, I wouldn't respond well to just being put into a cookie cutter kind of process, right?
I know, especially when you're talking about people. If there's going to be an exception, it's going to be a person, and people do not fit any particular mold, because we all come with our own life experiences. We all come with our own ideals, our own, thought processes and all of that stuff. So whenever we're talking about doing something in this sense, where we're treating the mind, we're treating the body, it has to be, you're going to have to make an exception, and that's just how it is.
Yeah. How do you, actually, let's back up to this. If I'm in there and I go into your program, what's the first thing that happens to me? How do we start to discuss and individualize what kind of stuff am I going to go through?
So I'm just going to make it a kind of simple, break it down. So you come into the facility, like I said, you do that medical assessment, you do that mental health assessment. We're doing that UA. Based on those results, will determine on where you're placed in the program. So if you're, positive for, fentanyl, you're going to go to medical detox. But if you're there because you have thoughts of suicide, and maybe you just smoke, meth every once in a while or anything along those lines, and you're safe, in terms of that acute, detox period, then you go over to the mental health side. And so then on the mental health side, you'll meet with a BHC, behavioral health counselor, every day. They'll work on that care plan. What does that look like? You'll also work with probably a mental health professional nurse, an MHPRN, who will do your mental health nurse shift assessment. You're going to meet with the psych, ARNP. They're going to talk about what medications have worked with you in the past. What works, what would you like to try? What can we do? We do try different therapies. The facility that I work at is actually kind of new. So we opened in October of 2021. And so we're still building and we're still expanding. But if you're in the medical detox, right? So we're going to start you on Suboxone or lorazepam if it's alcohol. And we're going to start that taper. We're going to start doing all those things. Find out, do you have a primary care doctor? Because when you leave, who's going to follow up on the Suboxone? When you leave, who's going to, and so in my facility, because we see a lot of homeless people, because we don't just take referrals from law enforcement, we take referrals from the homeless shelters, from the emergency rooms, all that kind of stuff. So we have to follow up, because Hep C is huge. HIV is growing in the state of Washington. So just following up, what blood work needs to be done. Is there a suspicion of a STI or UTI or anything along those lines? And then in the co-occurring program, that's when it's kind of like a little bit of a breath because we have, 28 days. So they'll go to group. They'll have a peer, and so the peers go out on the floor and they talk to everybody. What's your housing situation? Can we get you into long-term housing? Is your housing safe? Because that's a huge piece, especially when you're talking about domestic violence. And that could look like a lot of different things. Let's say we have a veteran come in and you know what? The VA is able to provide them with so many more services. How can we safely transfer this client from us to them to get them more opportunity for better success? So it's kind of in a nutshell, that's how it kind of breaks down. So we have a medical provider, we have a psych provider. And we just kind of get in there and figure out what we can do.
It's nice because it sounds like one of the things you're trying to do is make sure that whatever happens while they spend time with you all matters later. In other words, that you're maximizing the opportunity they have for this to be life-changing and actual a course of treatment, lining up with aftercare and what we used to call wraparound services when I started. I don't know if they still use that term.
You could call it holistic as well, I think, honestly, when you're looking at the person, and all the things that go into being a person.
Mm-hmm. Yeah. Yeah. And that's the part that is so needed in any kind of program like this, is to feel like a human being, because sometimes there is that element of being told what I'm like and how I'm feeling and what I need, rather than, and even when it's not, because a court ordered obviously can feel that way because you're ordered to do something, and sometimes it's very specific, and sometimes it's issued by people who aren't professionals in the field that don't really know, like, go get this kind of treatment. Oh, well, I went to 5 therapists and they'd never heard of that, but yet they all did things that would have met that criteria. There is that. But I think also sometimes just in an individual therapy encounter, sometimes it's like, oh, here's the program I run everyone through, or here's the method I always use. Oh, and you have this. Oh, you have addiction. That means you got to go do this and this and this, or else I'm going to tell you that you're not getting better, or you're not taking it seriously. And there is a tendency to be run through that in the culture of treatment sometimes.
Oh, absolutely. And I will say, Dwight, one of the things that I cherish about my team, especially, I 100% bring on the individuals who have a history, whether they have their own mental health or they're in their own recovery, because they can present, they can show up to work, and they can do it in such a sense of empathy that is learned from their own experiences. So with that, it gives them a step up, because it gives them that moment where when we're tired because we just got yelled at by a client and all the things are happening on the floor, taking a step back and thinking, how would I respond if I was in this facility for 20 some days and I didn't have my own shower and it's loud and there's lights and I can't sleep? and I haven't talked to my kid, or I haven't talked to my mother, or I haven't, you know what I mean? Like, so it gives them that opportunity to really be human and not just, oh, another client's freaking out, you know? And so it really changes the whole dynamic of our facility because we have those different things in place.
Are you guys more of a harm reduction orientation philosophically, or is it more based off of a abstinence expectation of substance abuse, or do you feel like it even fits into one of those molds?
I don't think it fits in.
Okay.
I don't think that is, because again, it goes back to the individual person, right? And sometimes, you know, that means methadone, and sometimes that means Suboxone. And sometimes when the clients are there for so long, they try and taper themselves off of it. And so that is the conversation that we have, you know, what is this going to look like when you are out in the community? You have a bad day. What's your resources? What are you going to do? How are you going to cope with what's going on? And so we absolutely work with the local methadone clinics. We also work with other, Suboxone prescribers and that kind of thing in the community to ensure, like, okay, this is where we're at. Now, absolutely, everybody who comes in who's on an opioid protocol, they get Narcan because it needs to be in the community. It doesn't need to be in a medical facility. It needs to be out on the streets, in the homes, you know, in someone's backpack, purse, whatever it is, because that's where it's going to save someone.
Yeah, it's such a huge thing with the fentanyl poisoning dynamic that you see here too. I have a neighbor who's a librarian, and they keep Narcan there in the library for people, and just testing kits and other things like that you're seeing people being supplied with now. And it's always good to see that that's being addressed, because we've had it's record numbers. I mean, you know, people who aren't making it. I've also been really grateful over the years, and I guess, you know, it's my age here, but I've been around long enough to see when almost everywhere I worked, somebody, even, you know, professional clinicians would say things like, I don't know about some of these medical treatments, Suboxone, for example, when it started becoming a thing, and, you know, people having issues with that. I've been grateful to see that that's become more of a accepted standard of care, to use medication to treat a medical problem. I know it's radical, but, you know, thinking of that issue, that sometimes we still have a hard time accepting that addiction is a medical problem, and so therefore dependence and withdrawal can be treated in many cases. And I've just seen how many people's lives have been changed with that. So I'm glad to see people are doing it and not fighting it as much as they used to. I don't know what you see in your community.
So one of the things, you know, to that, when I think of substance use, and I know how closely related substance use and mental health is, I think of it as an infected wound, right? So you have a foreign object and then you have an infection. Both have to be treated. The foreign object needs to be removed and the infection needs to be treated. And that's how that approaches with mental health and substance use, right? And which one came first is irrelevant. I think the question is, how can we, because if you don't treat one or the other, you're going to end up back at square one. And you really are. So if we're using medication to get them through that, then that's harm reduction. And I'm just happy to see that they're alive. And we will have clients who come back and they're upset because they see me and they're like, Brie, I didn't want to do this. And it's like, I don't care. I'm just happy to see you. That's it. You know, just, you know, because they get down on themselves. They feel that shame. And that shame alone is such a burden to carry. And I don't want to add to that burden. I was like, you're human. I'm human. And you know what? So what? You're here. I get to talk to you for a couple of days. Big deal. You know, it's just one of those things. And, you know, if I do see them, I know that they're alive. And that's really, sometimes that's all I can ask for, especially with because any medical professional, it's that revolving door sometimes, and it feels that way. Especially when you put your heart and soul into it and you're having hours of conversation and you're making all these phone calls and you're setting them up for all these things. But at the end of the day, they're a person and they're not perfect. And when we set them up for that, we are just setting them up for failure, and they feel it more and they live with this shame and this guilt. And it's sad. And so then they come in, I'm just happy to see you. I mean, it'd be great if we could meet at the store or something, but here's okay too.
It's interesting to remember when I very first started working in this field. In fact, in graduate school, I remember them talking about this, that you need to get people off of the drugs and off of the alcohol for a period of time before you can even really assess their mental health needs. And you definitely can't treat them until they are sober to some extent. And that, it wasn't very long before that didn't seem right. If you just worked with people and just talked to them and saw that, yeah, that's like saying you can't treat, I don't know. I mean, to me, it almost seems like, you can't treat your joint pain until you treat your heart attack symptoms first. It's like, well, okay, if the heart attack, so which one of these is the heart attack is what you determine, the one that might kill me. But if it's just like general cardiological health, you don't necessarily, you treat them both, right? You're like, oh, it's joint pain and, and your heart, you have a heart condition. Why would we say that, but that's the old wisdom, so to speak, right? Is that you can't focus on it until.
In my facility, we are absolutely cautious, when we're putting different things in. Yeah, we put a provisional diagnosis in based off of what we are currently seeing. But for something like methamphetamine, that, meth-induced psychosis could wear off in a couple days. And so we're going to reevaluate. And the care plan's going to change. And the medications we might use to treat the underlying depression or the underlying anxiety or whatever it may be, that's what's going to happen. That's what's going to evolve. And that's where I have to say I have amazing providers. From the medical standpoint, yeah, they're going to detox, right? And when you detox from something like methamphetamine, we're going to do all the anxiety stuff, the hydroxyzine, the clonidine, the gabapentin. And when you're talking about, fentanyl, yeah, you're going to need Zofran on board. Yeah, you're going to need, all these, Robaxin or whatever it may be. And so regardless of kind of where they're at, you have to change a care plan, but the person is also going to change as we're getting into, quote unquote baseline. And sometimes you're never going to know what that baseline is. And, one of the things that my team works really hard on is that collaboration of care, right? And so we have a couple other, medical facilities in Spokane that are exceptional at making sure that I have collateral information. When was the last time this person has attempted suicide? What medications worked for them? What was their last labs? Like, where's the liver enzymes? Where are we at? Is this something that's critical, something that's not? And Dwight, I got a great story for you. So we worked really close with one of the heart clinics here in Spokane. Guy needed a heart transplant. And he didn't qualify for it because of his addiction problem. And so he went on hospice. Well, he was still alive 6 months later. And so he was discharged from hospice. So we got him into the facility. We detoxed him and we got him into the 28th day at our facility, continued all the heart stuff, continued to get him where he needed to be. And he wanted a longer program outside of us to continue to, do what he needed to do to get back on that heart transplant list. And that's just like those little things, and that's just really cool. So,
yeah. No, that is really cool when you factor that in to say, because oftentimes that's just a no-go, right? I mean, a transplant committee or whoever it is that approves that is going to say, oh, sorry. And to have a pathway. And I can only go ahead. I don't know how it was for this individual, but if I'm told, yeah, you need a heart transplant and you're close to death and you're not going to get one, that's not going to trigger me to do less addictive behaviors because I'm going to die anyway. And that's what people forget, that becomes the coping mechanism. This is where, addiction is an attempt at a solution. It isn't a problem until it becomes, it becomes the problem we focus on when it is actually a way to deal with, right, a problem. Yeah. And so that's really fascinating and powerful change in someone's life to literal life-saving, by the way. I mean, if we want to really talk about it, it's like he's still alive, whereas he wouldn't be without that intervention. Because think about that too, of how much does that make someone feel when you're going through a program of health management for yourself. You're going to your doctor, you're going to whatever, and it's like, no. And somehow you're just going to be like, oh, all right. I mean, that's not for me. Treatment and help, that's not for me. It doesn't exist for me. And, a lot of people who are into addictive problems, a lot of people who have psychological disorders or a history of trauma, they've been through a lot already. They've been kicked around a lot, right? And so it's easy to say, oh, I'm that person. This just confirms an internal belief I have that I don't deserve to be happy.
Exactly. You are so right about that. And we see it, and one of the things that I find really fascinating, even going back to some of the old ways of thinking in terms of dare, and that kind of thing, and they're like, oh, they need to know if they use this, they could die. They know that.
Most of them know that.
They're not dumb individuals. They're individuals who have an addiction, who probably at some point, either whether it's the addiction or it's living circumstances or whatever, at some point they, and I've had these conversations with many clients, I don't care. I don't care if I die. And that's the heartbreaking part, because their quality of life is so down and so low, because whether it's the addiction has completely consumed them, their mental health has completely consumed them, that they don't have a quality of life. And so this is kind of goes back into my, my hospice brain, as the nurse, like, what is the quality of life, and what are we doing? Because if someone's like completely miserable and they're just facing all these social determinants, convincing them to live is very difficult. Convincing that they're worth something is very difficult. And so you have to get past those building blocks to being a person and a whole person.
Yeah. I love how you say that. The risk to the quality of life is, in some ways, I feel like greater. That might sound funny to say. I've said that on the show before, where it's like, yeah, okay, greater risk may be suicide in the sense that you don't come back from that if you complete it. However, most people, the reason I say the statistically more common risk is ruining of the quality of life, because most people who are suicidal don't kill themselves. Most people don't follow through all the way with it successfully, or even make the majority of people who feel that, if they were, we wouldn't have as many people. Let's be honest, because it's much more common than people think to go through suicidal ideation. But
Absolutely.
What does happen is that it tanks the quality of life, which then affects the quality of life of those around me. When I'm in a crisis, then boy, my family and my workplace, and you could say, and I think we're seeing this now, the overall economy, things like that, especially with our kind of largely unprocessed societal traumas we've been through over the last few years, and just all those things where it's this very real effect that it has, that are involved in our day to day. There's more to being healthy than just avoiding death. I'm sure. I've never been to nursing school, but I don't know if they start out by saying like, let's just avoid death. That's it. And no other issues.
We do have the running joke, but did you die?
I was curious about some of the struggles of individualization in the treatment. That's, as I mentioned earlier, that's why a lot of programs don't really individualize as much as they probably should. That's changing. That individualization is becoming more and more the norm. I'm not trying to put anyone in particular down, but bringing that into the program, what are some of the things that make that difficult, would you say, or how do you guys address the difficulties?
So staffing, right, is always one of those things, especially when someone needs, an ID, taking somebody down to the DMV and waiting and that kind of thing. Follow-up appointments, right, because they had a bad scan and they need to follow up on it. So that appointment can take a really long time, which is removing somebody from the facility, a van, that kind of thing. So we prioritize, right? So medical emergencies or acute stuff that needs to be addressed right away. Otherwise, that appointment's not going to be for another 6 weeks. No, we need to make that a priority. When it comes to different IDs and stuff, we do absolutely everything we can online. Sit down with them with the laptop, filling things out, whether it's FMLA or whatever that kind of looks like for that individual. Some of the hardships that we see on the floor, well, so-and-so can do this, why can't I? And, and it's just like they've learned a lot of these behaviors to get their needs met, whether they still serve them or not. And so identifying that, right? So when it comes to, we have Bibles on the floor. Cool. We also have different tarot cards and we have different things like that. Because it has to be fair across the board, especially when we're talking about those kind of religious things. When everyone wears scrubs, nobody gets to wear anything kind of special. We're all in blue scrubs. We have slides. One of the things that the program itself is trying to implement is for the female clients, self-care. And that looks like putting on makeup. So one day a week, they can, put on the makeup and feel human again, feel pretty. And so because of razors and that kind of thing, so I have to think in that sense because I'm the nurse. And when you're stopping somebody from self-harming, that's the first thing you're going to is what can be safe on the floor versus what can we do? And you would be surprised what people, what creative items I have seen. You wouldn't believe it. I got stories for days. But
first time I saw somebody cut themselves with a paint chip that they had peeled out of a seclusion room. I was like, oh, wow, that is inventive. People are going to harm you got to address that underlying cause or people are going to find a way to harm themselves. Yeah, for sure.
So a really great example of this is some of the female clients, they were taking the strings from the tampon to thread, facial hair. So let's just get actual sanitary thread to do this, to prevent us using, and a lot of those, skills, if you will, is learned, right? From whether it's prison, jail, life, mom showed me how to do it. So this is what I'm doing. And you would be surprised how intertwined that is. And like, for me, I'm sitting there, I'm like, first of all, I've never done that. Never thought about it. But it's one of those things. So just trying to do things safely.
I sat in I was helping out. It was some training thing I did a long time ago in an intensive outpatient program. And people came in almost every day to this program. And it was somebody brought a gift for someone else. It was this nice thing. They're like, hey, I found this at a thrift store and I know so-and-so would really like this. It really ties in with their background. The people got very tight with each other working through these programs together. And the person wasn't there that day. And a lot of the individuals had been in the criminal justice system, had lost their license, a lot of bicycling and bus riding going on. Mm-hmm. And it was interesting because like the next day or day after, something like that, this person showed up. And then the gift giver was like, oh, hey, I have a gift for you. Hang on. Left, came back with it. And we knew that the person didn't drive. And one of the counselors was like, hey, what'd you do with that? How did you get that? Did you bring it with you? And there's, oh no, when he wasn't there the other day, went into the office and hid it in a location in the building somewhere that it'll probably be fine and I'll be able to get it and I won't have to lug it on the bus, this gift. And I was like, that's very clever. But it's like, it wouldn't occur to a lot of us to say, let me find a dark corner somewhere in this building that doesn't belong to me, that I don't always have access to and be able to find it in 2 days. I don't know, just reminded me of that as you're saying. There's an innovation and a creativity that goes into surviving in life.
Absolutely.
Yeah.
Absolutely.
And I like that you're trying to shape that. You're trying to shape people into using that ingenuity or using that drive to find actual solutions that are going to long-term work better.
Yeah, absolutely. And then my brain, the way it works is like, okay, if we're going to do this, how can we do it safely? If this is going to interfere with your treatment, then what can we do? How can we work around it? So like if you have a female client who has alopecia, and she's used to wearing certain types of makeup to have hair. Obviously, without it, going to group every day, living with these people every day, it's going to interfere with her treatment because this is going to be her hyper focus. So if that's something we have to do, then that's what we're going to do.
Yeah. Interesting. And so a lot of that then also includes the need for communication, as you put it, staffing, communicating staff with each other, but obviously communicating with the patients as well is a big part of that.
Yes.
Process.
I have walked into the group room a couple times because we were using pencils, coloring pencils for makeup, and I walk in, I was like, guys, you keep doing this, pencils are coming off the floor, period. So you decide, let me know. I'll judge by all the facial stuff. But
you can tell if someone's been doing.
Yeah, right. Well, how did you get blue eyeshadow? Because it's a great color on you, but the blue pencil is now MIA.
Do you find this might be hard to measure depending on what you've seen and stuff, but do you find less of the sneaking around behavior that is typically talked about in some of these programs? I don't even know if that's a good question. I just know that, but that gets into the adversarial nature of treatment versus patient sometimes that I, at least reading between the lines, I think you guys try to avoid that thinking. And I think most modern treatment is best avoiding the adversarial nature, but I just wonder if you find that.
I'll be very transparent. Drugs have gotten on the floor 100%, because we don't search cavities, and that's just, that's the way of the world. Yeah. And so with that being said, we are beauty, again, back to being a volunteer facility. Somebody will say something. When something is not going, whether they are being bullied or there's paraphernalia on the floor, or somebody's doing something they shouldn't do, obviously we have staff, we have eyes on 24/7, all that kind of stuff. But when you have all these moving parts, things get missed. And that's just the nature of it. But because you have people there who want to be there, you have, hey, and because it's dangerous. So I'm detoxing people. If they get their hands on something, I could be looking at overdoses on the floor. And so immediately shake up the house. It's really frustrating. Everyone gets a little pack of Oreos or something to make it a little bit better. But everyone's going for UA. Bed searches are getting done. We are stripping the house, making sure that it's a safe environment, because they're so vulnerable at that stage, right? Because it's there. They have access to it. And so we have to be that, that intervention, whatever that looks like.
Well, and it's interesting though, because you don't lean the needle really hard into the let's be probation officers territory that some programs do to make sure it never comes in. It's more, no, we have a strategy for when we have the problem. That's the solution part, is when we actually have the problem. That I think that's really good, because stuff happens in the world too. And what are you prepping people for? If it's like, oh, as long as I can live like I'm in jail, I won't use.
You remember that really fantastic, also simultaneously awful study, the Stanford prison experiment, right?
Yeah.
So here we are, and this is why I absolutely love hiring individuals who've been in those shoes, because it's a locked facility, right? You have me. I get to come and go. I get to eat what I want for lunch. I get to go outside when I want to go outside. I get to use a phone when I need to use a phone. And they don't have that, right? So you have that imbalance, right? And so because of that imbalance, we have certain rules on the floor, set up. Like there is no touching. There is no hugging. And so when somebody's in like a crisis, I will absolutely like hold a hand or something along those lines, but it doesn't go any further than that. Certain medical procedures we don't do, because how can you determine autonomy in that kind of setting? So working with the staff, like, hey, this is not a power struggle. We are people who need to talk like people to people. And so it does take training. But I will tell you that the staff who have that personal investment I mean, they just come in level-headed because they know they've been there, they know what it feels like. And so it gives us this really great opportunity to have open communication with the clients, especially when you have, just somebody mistreating somebody, or you have something on the floor that shouldn't be on the floor, or you have, two people who decided to be in a relationship, because it is male and female. And the layout is set really fascinating. So we have just beds kind of grouped into areas. It's all half walls. So it looks a lot like a shelter. Everyone has their own private cubicle, if you will. The bathrooms are gender neutral. So there's no, you go in the bathroom, you better lock the door because someone else is going to walk in on you. So it gives them a sense of community. And that piece, being able to see what's going on, because I can look across the milieu and I can see exactly what's happening, even across the beds, and that's that part of that safety. Because in this, again, we go back to those learning, coping mechanisms / learning, learned skills or learned, life. What's the word I'm looking for? When people learn how to obtain the things that they need, whether they still serve them, like fighting for something versus having an adult conversation about it, that kind of thing. So yeah, it's really cool when you're in the program, you're looking at it and you're just seeing all these pieces kind of flow together.
What does that mean to you personally? What does it mean to you to be attached to this work, this program?
So I have to say I have my personal investments in it from where I come from. And because of that, it's me doing, I'll just say it, it gives my pain purpose. And because of that, if I can change and I can see things a little bit differently and I can improve upon quality of life, not just for the clients, but for my staff as well, then that's what I'm going to do. Because I understand, not me personally in addiction, but I grew up around it and I felt those effects and I know what it's like. And so if I had to endure that, let me do something with it. If I learned it that way, let me figure out how I can change it and be better and make opportunities for other kids who are in a situation like I was in. So.
Well, it's great work to be doing. I'm glad to see more and more of these programs start to crop up, and it also helps the community in lots of different ways when they're, and also, there's lots of back and forth over how, I don't know how things are enforced legally or whatever. There's a lot of ongoing social discussions and things that we need to be having. However, it's also nice because it gives those that are first responders and things, it gives them options other than just control the behavior of an individual. And, with those options there, someone might be more apt to do something that has a happier ending than some of the encounters people have, let's say it that way. And those options protect everybody. So that's really good. Well, one of the things I do with people who come on the show is I always ask people to share something about a community cause or a charity or something that they are attached to or that they care about themselves. Doesn't have to be connected with what we're talking about. However, of course, you and what we're talking about today is a nonprofit program. It is something that people can get involved in. So I want to make sure to highlight that and how people contact in that. And then I'd love to invite you to throw anything else in there if there's any other community give back efforts people could make, or if there's other charities that you believe in that may or may not be connected to this type of work. So we can start out with either one. Do you want to tell people how to find get involved with Pioneer Human? I'm sure there's a way.
Yeah, so it's Pioneer Human Services. It is a .com. It's not a .org, which is kind of weird, but it is a nonprofit organization. Most of the locations are located in Seattle area, but they have different sites throughout Washington State. So I would probably recommend just Googling it personally. Some of the other community stuff that I am so grateful for, and it is honestly related to my what I do. The Chaz Health Clinic They have their street medicine team. So when I have somebody who leaves AMA who needs to follow up on medications, whether it's, a chronic illness or something like that, those guys are stars and they just are amazing. And they just serve our people. They really do. When we're talking about different shelters and stuff in the city, Jules Helping Hands, she's an amazing woman who does everything that she can. And one of the things for me personally, I would say helpusadopt.org. It's a nonprofit that helps offset the cost of adoption. And so that is something I was personally volunteered with back in Philadelphia. They are just a beautiful group of people who come together to make adoption possible. And so there's that.
Wonderful. Thank you so much for sharing that. By the way, people who are in the Washington, Spokane, or Seattle area particularly, you'd said volunteer. Is this something that if people have the inclination or the ability that they should look into? Obviously, they can make donations and things to support it. Are there potential volunteer opportunities for people?
Yeah, I don't see why. So there's, of course, paperwork that has to be filled out because protective health information, that kind of thing. But when we're talking about like donations, I would say one of the things that's kind of a barrier that would be super helpful is cigarettes. People who are detoxing, they smoke cigarettes. I'm all about harm reduction. So if that's the thing that calms them down for now, who cares? Sure. But cigarettes can be, expensive and that kind of thing. Clothing for interviews, when we're talking about all of that. And as well as food. I know that sounds crazy, but the cost of food right now is through the roof. Yeah. And when somebody is detoxing, they can eat a grocery store. So, yeah, all of those things are, because I'm a little hesitant when it comes to monetary, donations and stuff. But if I can actually do something tangible, then that's the route I personally like to go. So yeah.
So those types of donations people could just bring in are things that you guys would accept of like,
yeah.
Here's a bunch of neckties or something. For interviews is what I was thinking. Yeah. So you said job interviews. That's why I said, in case someone out there's like, do I just have a stroke? Why did he say that? Well, thank you so much, Briana, for being here and for the work you're doing.
Of course. Thank you.
Thank you for listening to the Court Arts Podcast Network. To listen to more Court Arts shows, visit courtemparts.com.